So my presentation, the plan was to sort of go through a basic why do we need this session, and then to actually go on to some clinical cases. Because your time is quite limited though, I wonder whether we should sort of dive in somewhere in the middle. So basically the really important thing is to make sure that the GPs have got a really good grasp of the basic management of eczema, because the time that you're able to spend with the parents and the knowledge that you are able to give to the parents is the most important thing. As GPs, you can't manage those children yourselves. What you need to do is to teach those parents to manage the eczema, because you're not there every day, and this eczema changes from day to day. One day it will be fine, the next day it will be something else, and that parent needs to know how the eczema is looking today and how they need to actually react to it and how they need to be treating that on a daily basis. There are a lot of parental concerns when the parents reach secondary care. They have accumulated a lot of issues. The child is not sleeping, therefore the parent is not sleeping. They are worried about steroids. By the time they reach secondary care, the GP has given them some steroids, and the usual story is that they've had 7 days of steroids. The skin maybe got a little bit better, and then they stopped the steroids, and then the eczema flared again. And that kept on happening. That keeps on happening because that's what eczema does. If that's how you manage eczema, that's what it will do. But when it gets to the stage where the eczema keeps on flaring, the parents start to think, what is it that's causing this eczema to flare? They don't understand that eczema will often just flare of its own accord if it is not managed properly. If it is managed properly, then the eczema you've got a really good chance of actually keeping it under control. But poorly managed eczema causes those parents to think about other things. Could it be some allergy that's causing my child's eczema? We know that eczema is not caused by allergy. We know that eczema is an intrinsic defect of the skin barrier. And as a result of that, we've got allergy that can develop in these patients. The parents always want to know the cause, but we can't answer that. What we can do is teach them how to manage that eczema. There's a huge amount of reliable information that's available. It's available to us and it's available to parents, but both of us need to be aware of where to actually access that information. And hopefully that was what I was hoping to also try and share with you today. Prescribing topical treatments. Often we'll have patients that come to us and say, well, the GP gave me some moisturizers, they gave me some steroids.
You'll find on the wardrobe this.
Sorry, are you okay?
Yeah, I think that's the office maybe where I can put the mic off. Yeah. Thank
you. So just giving them the topical steroid and giving them moisturizer without an explanation is really no use at all unless they know how to use it. That is great for the children who've got mild eczema. We should be able to manage those mild eczemas with moisturizers and steroids with proper advice. But obviously there are a number of cases when that is not enough, and there are other issues that are actually at play here. So, like I said, it is empowering those patients with the knowledge. The other factor is we need a lot of time in clinic, but also the parents need to invest a lot of time in managing the eczema. It's not like some other conditions where the doctor will give the patient a couple of pills to take in the morning and the night. It's not that. The parents really need to invest their time in managing the eczema. We need to provide the parents with the explanation of how to manage the eczema, but the parents need to translate that explanation into, depending on the child's age, they need to translate that to the child in a way that the child can understand. Obviously, when we see a patient in clinic, we engage with the child. We try to make the child comfortable. We try to make them happy that they're in clinic with us, and we try to tell them that we will help them. But it's the parent that knows the child and knows how to encourage them to accept the treatments that are being given, and to understand the reasons for the treatments being given, and to understand that the treatments that are being given are going to help their eczema. It is going to make them more comfortable. It is going to help them to sleep. It is going to help mom and dad to sleep. It will make my life better. Okay. So I have a lot of cases actually that I was wanting to discuss with you. Because your time is limited, I've taken a few shots from the NICE guidelines on eczema, and it talks about providing information. So we need to really emphasize that eczema is a chronic illness that is characterized by flares. So it will go up and down, and this needs to be controlled with the topical steroids. This is what eczema does. It's not that we are missing anything in general. Okay, so I take a lot of time in clinic to explain the importance of emollient. Sometimes the parents will have been given in primary care, they'll have been given some moisturizers and they will have been given some steroids. They might not understand the need for both of them. They might not understand when they need to use each one or why they need to use each one. But it's really important that they understand the reason for it, because then maybe we've got a chance that they will use it and they will keep on using it appropriately. So I take a lot of time to explain the skin barrier. So this is taken from a leaflet from the National Eczema Society. It's called All About Eczema. It's actually an information pack that is available to be downloaded, that the parents can give to schools, because school is another area that needs to be aware of how to manage eczema when these children get a bit older. So this picture is showing some cells in the epidermis, the top one. And you can see some lovely plump cells, plump epidermal cells that have got plenty of water. And in yellow, you've got the fats and the natural oils. So this is what a normal skin should look like. And it's like a brick wall. It's solid and it's keeping out the allergens. It's effective in keeping out the allergens. In the second picture, we've got skin where the person has got eczema. And you can see that difference in the cells. The cells don't have all that water. They're slightly shrunken. And the surrounding area, the surround where usually you would have plenty of fat, plenty of natural oil, that's depleted in eczematous skin. And so you've got these big gaps appearing. And what's going to happen with those gaps? Well, irritants are going to penetrate through that epidermis, and allergens are going to penetrate through that epidermis because it's completely broken. It's not intact. And that's a genetic tendency that this child has got to developing eczema. That's what they have, but that's what we need to help them to actually manage. And that's the basis for prescribing these emollients, because in the bottom picture, you can see when we are giving them emollients, we're filling those gaps with the fats and with the natural oils. So the ointments that we're providing are trying to improve that skin barrier. And that will happen over a long period of time. And that's why we need to continually treat them with moisturizers. It's not a case of treating them with moisturizers whilst their skin is flared. It's treating them with moisturizers plus steroids when their skin is flared, settling their skin. And once their skin is settled, we need to maintain that skin, and we need to keep on giving them moisturizers so that skin barrier is really gotten to the stage where it is the best that it can be. And then you've got less of a chance of things that are going to cause irritation to the skin. You've got less of a chance of irritants manifesting in the skin with eczema. And you've got less of a chance of allergens being introduced into the skin, which can cause them a lot of problems. Okay, so that's a really nice picture, as I said, available from National Eczema Society under All About Eczema packs. So it may be something that's useful just to pictorially demonstrate to the patient. So epidermal abnormal skin barrier in eczema. A common question that we get asked in dermatology is this eczema going to go away? Clearly the eczema is having a massive impact on their life, and they want to know, is there an end in sight? It's really important to them to know this. And the good thing is we can say that about 80% or so of children, their eczema will improve by the time they get to their teens. Obviously, there are a significant percentage that will still go on to have problematic eczema in their teens and then going into their adulthoods. But actually, a lot of the young patients that we do see in clinic, if they get that right management at the initial stages and the parents know how to manage that eczema, there's a really good chance that we can make a very positive impact to the management of their eczema. The other thing is that inflammation further damages that skin barrier. So if we do have eczema that is active, we're perpetuating that inflammation, and we're perpetuating the gradual worsening of that skin barrier. And so we just need to try and break that cycle. So here's a child with hand eczema. Does anybody want to have a go at the sort of issues that we'll be thinking about? So this is about a 3-year-old child who's got this hand eczema. Does anybody want to have a little go? Or do you want me to just carry on? Is everyone still there? Can everyone still hear me?
Yes, we can hear you.
Yeah, okay. So this is a young child who's presented with hand eczema. So they had flexural eczema when they were younger, and now they've developed this hand eczema. So we need to take the history that's relevant to this child and then try and help them with their management. So the pattern of eczema can change over time through childhood. And hand eczema is quite common in toddlers. And usually the reason for this is that they've changed activity, they've changed what they're doing. They're now being exposed as toddlers to a lot more things that can irritate their skin. They've started handling things a lot more. They're needing to wash their hands a lot more. And clearly washing your hands is one of the things, washing your hands with soaps and various things that can irritate your skin is one of the things that is going to strip that barrier, strip those fats and strip those oils from their skin. So one of the ways that we try and address this is to get them to stop using their soaps and bubble baths, etc. It's really important. They might be starting to go to school at this stage when they come into contact with things like sand and mud, and again, the hand washing and lots of other things, Play-Doh. The most common thing that goes wrong is the irritant effect of these contact things. People often worry about allergic contact dermatitis as well, and that's a different entity. And obviously we do need to think about it when irritant eczema doesn't respond to treatment. But in general, it is just the irritant eczema. So we need to treat it with plenty of moisturizers, and moisturizers alone are not going to help this hand. They're going to help, but they're not going to treat. They're not going to touch the eczema that you have there. If the child has got redness, if they're itching, you can see the redness and you can see the scaling. You can see that the skin is quite thickened there as a result of the eczema, as a result of the scratching. And so this child needs topical steroids. One of the problems that we come across quite often when a patient's been referred with hand eczema is that they have been given some topical steroids by their GP, and they have been told, use this for 7 days for your eczema and then stop. And obviously the topical steroids come in various potencies, various strengths, and they may have been given the weakest steroid. So they may have been given some hydrocortisone cream. And using hydrocortisone cream for the eczema that we're seeing in front of us in this hand, hydrocortisone cream is not likely to touch this at all. Hydrocortisone is the weakest possible steroid. The next steroid up is things like Umivate and Betnovate. I'm just going to whiz down to this list of topical steroids, which is also accessible from the National Eczema Society. And so on the right-hand side, it tells you the potency of the steroids. You've got a number of steroids in the mild category. You've got a number of different steroids in the moderate category. So you've got Betnovate RD, for example. You've got Umivate, which is clobetasone butyrate. And then you've got steroids in the potent category. And one of the ones that we use often would be Elicon ointment. And there's Diprosone ointment, which is another slightly stronger steroid. And then down at the bottom, you've got Dermavate, which is a very, very potent steroid. So between these various categories, so a moderate steroid is about 4 times stronger than a mild steroid. A potent steroid is about 4 times stronger than a moderate steroid. And a very potent steroid, right down at the bottom, is 4 times stronger than a potent steroid. So if you do the maths, between a mild steroid and a very potent steroid, there's actually 64 times difference in the strength of the steroid. And I write this down for the parents between mild, moderate, potent, and very potent. And when they understand that there's a 64 times difference in strength between those steroids, that just makes them a little bit happier to move up from just using hydrocortisone, because Umivate used to these hands is absolutely appropriate. As I said, hydrocortisone is not likely to touch that. That eczema has been there for a long time. It's established, it's chronic eczema, and it needs treating with at least a moderate steroid and for a longer period of time. I don't tell my patients to use the steroids for 7 days. I don't tell them to use it for 10 days. I don't even tell them to use it for 2 weeks. What I tell my patients is to use it until you see that improvement in the eczema actually happening. So if you look at this hand, you can see the skin markings are really quite prominent. That is not how a hand should be. So it's prominent because there is thickening of the skin. Therefore, we need to use the steroids long term to try and reduce the quality, to improve the quality of that skin back down to normal from what it was. And to do that takes time. It's not going to happen overnight. So I usually, for this kind of hand, what I would probably do is to start them off. If they've not used a moderate strength steroid, I would start them off on a moderate strength steroid. And I would tell them to use it for, at least 7 days and see how you're doing. If the eczema is starting to improve, fantastic. Just keep on going until the skin has really improved. And then you can start to cut down what happens, start to cut down what you're applying. If you've used it for 7 days and it's really not had any impact at all on the eczema, then I would probably increase the potency to short-term Elecon for a short period of time. It's really, really important to stress, however, that eczema is not managed purely with steroids. The steroids are there to damp down the inflammation. The steroids are there to treat all this redness that's there, all the eczema. But alongside the steroids, they need to be using plenty of moisturizers. And if they're using steroids, those moisturizers need to go on at least a couple of times a day. They also need to be avoiding those soaps that were stripping the skin of their oils, and they need to start using the soap substitutes. So they need to use their moisturizers as their soaps instead. And we often use a product called Dermol 500, which has got an antiseptic action, and that's quite useful. It comes as a pump pot and they can wash their hands with that. It's also really, really important that we ask the GPs to provide the patients with a couple of bottles so that one stays at home and one can go to school with the child, so that the child isn't doing things properly while they're at home, but when they go to school, they're stripping their hands by using really irritant detergents at school. So there's a whole range of moisturizers that we have available to us. These are just some that are available over the counter for parents to buy. So we have ointments, which have a lot more oil content. And then the creams have less oil content, and the lotions have even less oil content. So the greater the oil content, so the ointments would be much better for really dry skin. And I always try to start my patients on ointments if they can tolerate it. If they have really bad eczema and I've given them quite a strong steroid, I want to give them the best moisturizer that I can to give them the best chance of improving that eczema. The ointment, some patients will find it is messy. Some patients will find that ointments are a little bit tricky to use during the day, in which case that's fine. They can have 2 different preparations. They can have an ointment to use at night, and then during the daytime, they can have a lighter moisturizer in the form of a cream that they'd be more happy to use. Another little trick that I use for hand eczema is this fludroxycortide tape. So that's a steroid impregnated tape that they can wrap around individual fingers. So often with this hand eczema, they will often get cuts, painful cuts, little fissures occurring over the hands. And sometimes they can be quite difficult to treat. So actually taping this up with some steroid impregnated tape and doing that on a daily basis for around 7 days can really lead to a good improvement. And also the parents feel that they've been given something different to what they've had before. So they always come to us having been given various preparations by the GP, and to be given something different that gives them a little bit of hope, an extra hope, can sometimes be useful and can sometimes really, really help. When we give topical, so this is again a topical steroid ladder. This is from a random picture on the website that I picked up. And you can see on the left-hand side, you can see the various strengths of steroids. You've got the mild hydrocortisone, you've got the moderate Umivate and Betnovate RD, and you've got the potent Betnovate, Diprosone, and Elacon is in the potent as well. And in the very potent, you've got Dermavate. Now, one of the issues that the parents come across is all the advice that they get from various health practitioners. And it's usually really conflicting advice. And one person might tell them to use the steroid for 7 days. One might say to use it for 14 days. One might say, don't use it on the face or don't use it on the genitals. And another will say that's fine. So we just need to be able to give our patients advice that they know is safe to follow. So, for example, under moderate steroids, it says this particular table says avoid use on the eyelids. So the eyelids are not an uncommon place where we can get eczema. So obviously, initially, if someone has eyelid eczema, I would start with moisturizers, plenty of moisturizers. And I would start in the mild potency because the skin is really, really delicate over the eyelids. But if they've had hydrocortisone for, say, 7 days and it hasn't made any impact, what are we supposed to do? What is the patient supposed to do then with their eczema that's still active over the eyelids? We need to do something. So I would step up to something like Umivate, which is a moderate strength steroid, and use it short term. So often just a 5-day course of some Umivate will really make an impact on the eyelid eczema. And then you can very soon bring it back down to a less potent steroid. And hopefully in the slightly longer term, you can maintain that. But how do we maintain it? We maintain it with lots and lots of moisturizers to make sure that we're really replenishing that skin barrier. So, as I said, education is really the core of managing the most basic eczema. And the vast majority of the patients that reach our secondary care dermatology clinic have got mild eczema that is easily managed if treated properly. So we need to try and catch them at that stage before they develop other issues and other concerns. So this is another little boy who's been referred up with this itchy rash over the body. So does anyone want to have a little stab at what they think about this? Does anyone want to put their microphone on and speak to me?
Welcome. We have some new colleagues who joined. Please feel free to join and share your ideas. Safe space for learning. We're all learning. I am learning today more from Natasha. I'm Sarah,
please,
the pediatric consultant.
Yeah, please do put your microphones on and share. I'm afraid I can just see my PowerPoint presentation, so I can't see anything else. So just please do speak to me if you want to. That would be fantastic to have some input. If not, then I will carry on talking to myself. Anybody want to have a little go?
You're not talking to yourself, you're listening.
You said they are listening to what you're saying, Natasha.
They're listening. You're listening. Okay, fine. I will carry on. Okay, so this little boy has got some quite well-defined lesions over the chest. So he's been given some moisture, and it's itchy. So he's been given some moisturizers and some topical steroids because that's often a good place to start. when we don't know exactly, if somebody doesn't know what's going on, that's fine. But they've been given some emollients and they've been given some hydrocortisone, and he's used it for 7 days and there's been no change. There's been no improvement whatsoever. And so the parents then gone back to the GP. They've got a bit of eczema, a bit of redness over the face as well, and they're getting more of these lesions appearing over the chest. And you can see that the one quite low down on the right side is actually a little bit raised, and some of them are getting a bit raised, and some of them are getting a little bit weepy as well. You can see in the left axillary area, it's starting to weep, it's starting to break down. So the parent is getting worried, and the GP is starting to get worried as well, because the initial treatment hasn't worked and it is worsening. So they get sent into secondary care. And we have a little look, and there we have the back as well. So it's getting more widespread, and he's getting more and more lesions. So what are we dealing with here? So we know that atopic eczema, in our basic medical school training, we are taught that it affects the flexural areas. So the antecubital fossae, the popliteal fossae, the neck, sometimes the face. Those are the sort of common areas when eczema is localized and presenting in children. Those are the common areas that get it. But this child's got a very different pattern. And what this is discoid eczema. So it's still very much eczema. It's just a different pattern of eczema with these disc-shaped lesions. And it's very well recognized that it's just another presentation of eczema. And therefore, that's how we need to manage this child. So the fact that they haven't responded to hydrocortisone used for 7 days, with or without moisturizers, means nothing. The fact that they've not responded to a little bit of Humavate for a few days, again, means nothing. If you can make a confident diagnosis that this is discoid eczema, and you've made that diagnosis on the basis of the appearance, that they're quite well-defined lesions, that they're very, very itchy, and also they're a little bit weepy as well. And we know from the face, so sometimes we look elsewhere, and the actual lesions over the face look quite eczematous, don't they? That looks like a pretty typical eczematous face. It's poorly defined erythema that again is itchy for the child. So I'm quite happy. I'm very confident that this is discoid eczema. And what we need to do is to manage it as discoid eczema. And discoid eczema can be a little bit resistant to treatment sometimes. And we may need to really make sure that the potency of the steroid that we've offered is sufficient. We need to make sure that there's no infection. Now, even though those lesions looked a little bit weepy, in fact, they're likely to respond just to a potent steroid. There's not really any strong indication for giving an antibiotic. Some people may do, but actually they're probably going to do really well with a short burst of a potent steroid, but along with plenty of moisturizers. I keep on emphasizing this point, that just treating them with steroids and then taking it away, there's no doubt that that eczema is just going to come straight back, and it's going to be appearing in different places. And then everyone is going to think that this wasn't eczema in the first place. It is eczema, it's discoid eczema. And if we give them the appropriate potency steroid, and then we try to really maintain that skin barrier with plenty of moisturizers, make sure that there's no bubble baths going on, make sure that there's no irritants on the skin, then we should be able to get control and maintain control of that discoid eczema. Sometimes we get eczema that we can control, and then we keep them on moisturizers, but eczema will flare up all the time. And if we do have eczema that keeps on flaring, what do we have? What do we have that we can do? Well, there's a regime that we call maintenance steroids, and that's when we treat areas of skin that are normally affected with eczema. If they're frequently flaring very regularly, we will sometimes ask the patient to apply topical steroids to those areas where it frequently flares. Apply the steroids a couple of times a week, even if the skin is clear. So we're putting the regular moisturizer that they're always having, that needs to continue. And we're also using a topical steroid twice a week, even to completely clear skin, in order to prevent that eczema from becoming widely problematic again. And that usually works as well. So that's one of our other very easily fixed eczemas. Correct diagnosis, correct treatment, and the job is generally done and they can be discharged. Okay, so then we've got this little boy who's about 8 years old, and he has been referred with a fairly widespread rash, and it is progressively getting worse. So it's red. You can see a bit of scaling, particularly around the eyes. A little bit on the right temple. You can see that that lesion is a bit scaly as well. On the back, it's difficult to see, but we've got some fairly bright red lesions on the back. And this has been coming on over a number of months. So patient's been sent up to us because he's not responding to treatment. And of course, we take a look at this child and we're not dealing with eczema here. That's the thing we need. So it looks a little bit like our discoid eczema, except it's really it's much smaller little patches and plaques. On the body, it's not particularly scaly, which is quite common with pediatric psoriasis. But with pediatric psoriasis, we've got sometimes quite telltale periocular involvement. They can often get lesions around the eyes. So once we're actually able to give them a diagnosis of psoriasis, we can go down the psoriasis treatment route. Okay, but that's one of the other reasons why patients get referred to us as eczema that's not responding to treatment. We just need to make sure that we've got that treatment, we've got the diagnosis correct. So moving on to this little child who's got, we can see fairly widespread involvement here. So we can see there's facial involvement with erythema. There's some excoriation over his chest area. We can see poorly defined erythema and also extending onto the back. In his neck crease, you can see there's a little bit of erosion happening, and also you can see involvement of that hand. If you look at this next picture, really the most striking thing here are those hands that are really, really scratching at that skin. If you compare it to this child who's actually smiling at us, this is not itchy. Psoriasis is not itchy. So if you get a referral with, someone who's pretty okay, then we're not immediately thinking eczema. But if we get a referral with a child who's really distraught, then eczema until proven otherwise. The other thing that you can really notice about this child, if you look at his hands, they almost look like elephant skin. They're really thickened. That skin is really thrown into folds because of the skin thickening that's happened, because of the fact that this eczema has been going on for a long time and we haven't, and it has not so far been treated appropriately. We call that lichenification. And if we have lichenified skin, then we know this child is going to be with us for a little while. We're going to have to really work on this child. We're really going to have to support this child until we can get on top of this eczema. So here, 2 weeks of steroids is unlikely to do very much. We always need to take the prescription of steroids. We need to take into account what the child has had before. So if they've had nothing, then it may be that giving a moderate strength steroid is actually going to help significantly because they've not had that level of steroids before. But if they've already had moderate strength steroids along with plenty of moisturizers, so if they've actually been managed pretty well in primary care, but they just haven't responded, then that means that we need to go in with something a bit stronger. And the reason that we need to go in with something stronger is A, we know that Humavate hasn't done anything, so we need to give them a potent steroid to try and get control. But also, I feel we just need to give the parents a bit of confidence when they come in to see us, so that they know that we can do something for this child, hopefully. However, this is a young child and they have got widespread eczema. So we do need to think. So I always think at this stage, when I have a child who's been referred, who's very young and who's got really widespread eczema, I never fail to consider whether there is some other factor that's playing here, which is contributing to the really, really widespread eczema. So are there some other factors? For example, could there possibly be some kind of allergy that's exacerbating his eczema? It's important to note that the allergy has not caused the eczema, but the allergy can certainly drive this eczema and perpetuate it, and the eczema is going to gradually get worse and worse. And if there is allergy that is making this eczema worse, then despite my best efforts to treat this with topical steroids of an appropriate strength and moisturizers, it may be that I'm not going to win. If he's got something else that's driving this eczema, then we need to recognize that there could be something else that's driving this eczema. And we need to make sure that that is dealt with. So we need to take a pretty wide view when we're taking the history in this patient. So how are they generally? Have they got any other things going on? Is there something that's obviously flaring this eczema? How's his gut? Has he got any gut symptoms when he has particular foods, when he has his milk or whatever it is? Does his gut misbehave? Does he have diarrhea? Is he gaining weight? So you need to take a broader view when we've got eczema that's really very widespread. But I always start with managing the skin, unless there's a clear history that the patient has, for example, a particular food and he immediately reacts, then obviously that means a referral to allergy team, and we do that with no hesitation. But often, and you'll have learnt about IgE-mediated allergy, which is when they have an immediate reaction, and then it's obvious to everybody that this child is allergic, and they often get referred by the GP. Yeah. But there's also a non-IgE-mediated allergy, which is when they may be having amounts of allergenic foods that are slowly building up and slowly driving this eczema. And that's much, much more difficult to detect. And it's easier to detect that when we've managed to get better control of the eczema, if that's possible. So when we see this child, as per any child, what we're going to do is to prescribe the topical steroids and the emollients with appropriate advice on how to use them. Again, on this child's tummy, you can really see that skin being thrown into folds, thickened folds. That's not normal. Skin shouldn't really do that. You can see that they're actually quite prominent folds, and that's a sign that there's lichenification, that this eczema has been going on for a very long time, and there is thickening of the skin. So there's a lot of inflammation under the skin, and that is going to take a long time for us to get on top of. So we need to make sure that we've prescribed an appropriate strength topical steroids as per what we discussed. So depending on what they've already had and depending on how bad the eczema presents when he's seen in clinic. The other really important thing about prescribing topical steroids is to tell them how to prescribe the topical steroids. So we need to make sure that we advise them about fingertip units are one way of telling them how to apply the topical steroids. So if you squeeze the tube out from that first crease to the tip of the finger, of your finger, that should cover about 2 palms worth of the child's skin. That can be a little bit tricky with the parent continually measuring out as they try to apply it onto a screaming child. What I often say to the parent is, please make sure that the child's skin is shiny once you have put the topical steroid on. And that means that you've applied a good quantity, a sufficient quantity of topical steroid to have the effect that we want it to have. So topical steroids and moisturizers, we need to make sure that there is half an hour between the two of them so that their effect is not diluted by another. So if, for example, we've got this child who is under 2 and he's got very widespread eczema, it's difficult for the parent to target where they're putting the steroid because essentially his eczema is all over. There is no point in putting it onto little bits of skin. You can barely see any skin that's normal. Often parents will come to us with this idea that they're just going to treat the worst bit of eczema that they can see, and they leave the rest of the eczema because it hasn't got bad enough to treat. That is not the way to treat eczema. When I see my patients, I tell them at the earliest sign that you see any bit of eczema, or if you see any eczema that's even a little bit present, a little bit red, treat it early, because in the long run, you are going to end up using less steroid than if you allow it to really flare up, and then you're left with an extremely angry eczema. So treat it early, and then hopefully you'll avoid yourself further problems. So with this child who's under 2, so if we look down here where it says age, so 1 to 2 years, and then this chart gives you the number of fingertip units, so those number of those applications that we measured out that you need to cover that amount of skin. So this is again from National Eczema Society, which is a really good resource, really good source of information for us as doctors and particularly for parents as well. So if you add up the number of fingertip units, given that he's pretty much all covered, if you add up all these amounts of fingertip units, that comes to 13 units. So 13 units. So if you look up here, 1 fingertip unit is 0.5 grams. So that's 7 grams per application for this little child. So if this little child is going to have almost a full body application of the topical steroid that you've prescribed, that will be 7 grams per application. If he uses it for 5 days, that's more than 30 grams that's required. So often what we get when we ask for a prescription for topical steroids is that the parent is given a really small tube of 30 grams of whatever steroid we've asked for. So that steroid is really not going to last the course at all. So we need to make absolutely sure that our patients have got sufficient steroids in order to actually manage their skin. They can't keep on coming back for repeat prescriptions. They're probably not going to manage that. It takes a while. Obviously, you know the mechanics better than I do, but it takes a while for a prescription to go through. And by the time they've run out of steroids and they're waiting for the next one, this eczema has hugely flared again. So when the eczema is really widespread, I usually ask the GP, could you please prescribe the topical steroid that I've asked for in 100-gram tubes? And depending on how big the child is, they're going to need X amount of tubes per week, per month, whatever it is. Moisturizers, I always ask, 500-gram tubes might last just for 1 week, particularly when they're using it as a moisturizer and also as a soap substitute. They're going to get through 500 grams often in a week. When I say soap substitute, what I mean is we've asked these patients to stop using soaps and bubble baths to wash with. So instead of using that, they can use these moisturizers to wash with instead. And what I often say is to put the moisturizer onto the skin when the child is dry, not when they're actually in the bath. So if you put it when they're dry, it's going to stay on their skin. If you put it on their skin when they're in the bath, it's just going to float straight off. If you put the moisturizer onto their skin when they're dry, and if they then go into the bath, and when they're in the bath, you gently flannel their skin down, that ointment will turn white, it will turn creamy, and you keep rubbing them with a flannel or with their hand, and then that cream will slowly disappear, but leaving a good layer of moisture, an extra little bit of moisture onto their skin. So that's another really good way of introducing moisture, improving the skin barrier for them. Another way of, if things really haven't improved, or even at the outset, if the parent is keen, another thing that we could potentially do for this child is to introduce them to the suits. The parents have often looked into this already. Sometimes they may have bought things on the internet, but comfy fast suits, tubifast suits are all available. And there's a really good guide on the British Association of Dermatologists website, support and resources under video guides. Let me just see if I am able to play that for you. It just shows how to apply a comfy fast suit. Can you all see my screen at the minute with it moving around? Can you see that?
I can see the screen, but the video is not yet.
Yeah. Okay. Let me just stop sharing that. And window video guide. Oops, sorry.
So if you have questions, you can write it even in the chat, guys, or you can open the mic.
Hang on, I think it should be coming now. So I'll just let you have a listen to this rather than my voice. Can you hear?
Hello,
have you got
my name
to
is
that?
Heather and I'm a specialist nurse at St John's Institute of Dermatology.
Yeah, okay.
In this short video, we will explain and demonstrate how to apply wet wraps to a child as a treatment for eczema. Please note that this is a general guide and should not replace the advice given to you by your doctor or nurse. Wet wraps are made of elasticated material that are used with moisturising creams and other prescribed treatments to calm the skin during eczema flares. They also form a protective layer over the skin and prevent further damage from scratching. Wraps are most commonly used with emollient creams underneath, although they can be used with topical steroids for a short time. You will need the following equipment to wet wrap a large area of skin: 2 tops, 2 leggings, emollient cream, clean warm water in a bowl or sink, and something to distract your child, such as toys or a book. Start by bathing according to the advice you've been given. After a bath or shower, apply a thick layer of emollient to the skin from head to toe. Apply the emollient in downward strokes in the direction of hair growth. While the emollient is absorbing into the skin, prepare the wraps. Put one of the leggings and one of the tops into a bowl of warm water. Once they are fully soaked, remove them and squeeze the garments to remove excess water. The material should feel damp but not be dripping. Make sure that the labels and seams on the garments are worn on the outside of the garment. Roll the sleeves and body sections up. Put the top onto the child by gently stretching the head hole and pulling it over their head. Gradually roll the sleeves and body section down gently. Avoid overstretching the material as it can tear more easily when wet. Then do the same with the leggings. Gather up each leg of the garment and ask the child to step in. Gradually and gently pull each side up until the material is smooth on the legs. Try to do this as quickly as possible so that your child does not get too cold. Once the damp top and legging is on, put a dry top and legging over the top. The garment should be close to the skin but not too tight. You can leave the garments on for up to 24 hours. Most people find that they use wet wraps overnight and remove them in the morning, and use them more during flare-ups. If you think your child has a skin infection, wet wraps should not be used at the same time, as it can make the infection worse. They should also be avoided if the child has a fever or is generally unwell. If steroid creams are applied under wet wraps, this can make them stronger. Therefore, please ensure you carefully follow the advice given by your doctor or specialist nurse. The garments can be washed in the washing machine and reused. The instructions on how to do this come with the garment box. To cover a smaller area of eczema on the arm or leg, tubular bandages may be used instead of full garments. There are different sizes of tubular bandage for the size of area you wish to cover. To use a tubular bandage to wrap a smaller area, follow the same steps as applying a garment, but instead of using a garment, cut 2 pieces the same size from a roll of tubular bandage. Apply emollient to the skin with a steroid cream if you have been advised to do this by your doctor or nurse. Wet the first tubular bandage in the same way you would wet a garment. Apply this to the area being treated, then apply the second dry layer. The tubular bandages are slightly elasticated, so should stay in place, but if they fall down, an additional elasticated bandage or close-fitting clothing may be used to hold it in place. We hope you have found this video helpful. If you would like some further written information, please click on the link below to download a leaflet on how to apply wet wraps.
So that was, can you hear me again?
Yes.
So that was just a little video. So we use Comfy Fast and Tubifast suits quite often, and it's something that can be prescribed, obviously, in secondary care and can in primary care, and it can be really useful, particularly when these eczemas are so widespread and the child and the family are really struggling with the constant itching, the constant scratching. The child is awake all night and they just want some extra help. And we just need to help the moisturizers to penetrate a little bit better, the moisturizers or the steroids not to be immediately scratched off. These garments can just help to keep things in place and to be absorbed a little bit better. So we do use them quite often. They are a little bit of a performance for the parents to use, but they can be really beneficial. So it's just another thing that we can offer these patients to try and get it better. So moving on to this girl. So I'm getting the idea that you guys,
Natasha,
yeah.
we can't see the PowerPoint. I think
Oh, apologies.
you need to share them. Thank
Here
you.
we go. Yeah, sure. Sorry. Thank you, Sarah. Can you see that now?
Yes.
Yeah. So this is a girl in her teens who's presented with this. So she's got long-standing eczema, and the eczema has suddenly gotten worse. So this is a little bit more straightforward, slightly in terms of diagnosis. She's got clear weeping eczema over that face. Just wondering why that's not moving. There we go. So we can see the eczema that's weeping. So we know this eczema is not going to respond purely to topical steroids and moisturizers, and this person clearly needs extra something. So just have a little look at her face and just consider how you're going to treat this person. So I'm sure everybody's thought of giving some steroids, so probably some oral antibiotics for this patient as well. But I hope that some of you have also noticed these little punched out, eroded areas that are scattered over her face, over the cheeks, over the temple area, and over the forehead as well. So this is where we need to consider whether or not this patient has got an infection with herpes simplex. So eczema herpeticum is one of the dermatological emergencies which we can't afford to miss. So this patient is also going to need viral swabs to confirm the diagnosis. And then we also need to make sure that they get immediate treatment with some antivirals with some acyclovir. It's very close to the eye, so we also need to get an same-day ophthalmology review to make sure that they're not going to have any complications with the eyes. So we need to recognize that. So infection we all think of, we also need to make sure that we always consider whether or not there can be an extra eczema herpeticum as well. And these patients can be quite unwell with that as well. The other thing to mention with infections is that sometimes we find that when patients have recurrent infections, they may come to us with a prescription for something like Fusidin H or Fusibet cream. So that's got steroid and it's got antibiotic component. And the parents will find this an effective treatment, but following on from the effective treatment of an infection, what the parents will then go on to do is to use that as a long-term treatment for their eczema. But treating eczema with a long-term steroid plus antibiotic combination is not best practice at all. It's not what we recommend at all. What a patient needs is to have that antibiotic, the Fusidin component, as just a course of treatment, and then they need to go back to just the topical steroid, which can hopefully manage the skin by itself. And often, sometimes, even when the skin looks really infected, not really infected, but if it looks a little bit infected, often it will respond just to a good strength of steroid, because we know that patients who have eczema are often colonized with Staph aureus. So if you were to take a bacterial swab from a patient with eczema, it's usually going to come back with Staph aureus or another bacteria. That doesn't mean that they're infected. That doesn't mean they have an infection. It just means that they're colonized. So we don't need to necessarily treat that unless there are clinical signs of infection. But if we do have a patient who is having recurrent clinical infections superimposed on their eczema, what we need to think about is whether or not this patient is going to need some kind of decontamination to reduce their carriage of these colonizing bacteria. So what we would do is to take a swab from the patient's nose. We also often take a swab from the parents' noses to see if they're carriers as well. And often this might be commoner if the parents are, for example, healthcare workers, because they may be more likely to carry bugs in their nose as well. And if we do isolate bacteria, then the patient as well as the parents all need to undergo decolonization treatment. And that may well be really helpful in reducing the frequency of infections that our patients with eczema will get. And some patients really do struggle with recurrent infections constantly. This is one patient who had to be admitted to hospital because she had an infective flare of her eczema. Obviously, with any sudden flare of eczema, we do think of infective flares. And as I mentioned before, we do think of flares with eczema hepaticum. But this child has clearly got a significant facial flare of her eczema. The eczema was flared all over, but it was particularly over the face. She was infected, but her eczema baseline was always worsened over the face. And one of the things that we need to consider with exposed area flares is what other things could be triggering their eczema. So what other things could they be exposed to in their everyday lives? And obviously, pets are one of the major triggers. Pets, so dogs at home, cats at home, house dust mites. So environmental allergens we really need to think about. This child had a few cats at home. Her parents were separated and her father had a dog at home. When she went to her father's house, they also used to take her riding, horse riding, and she was actually significantly sensitized to horses. So with certain patterns of eczema, these are children that clearly get referred to secondary care. They have really widespread eczema, so we need to think about other things that could be flaring her eczema. Obviously, patients and parents are reluctant to reduce their exposure to various environmental allergens, particularly pets. But we need to make sure that we identify them and that we share this information with the parents so that they can make a very informed decision and a really important decision, really, when you think about it. If this child is having eczema like this, and her eczema was actually pretty constantly like this, she was always flared. Whenever I see her in clinic, her skin is pretty much always like this. And is this the sort of quality of life that we want our children to be having? We tried this child on second line treatment. So she was actually treated with methotrexate for a while. She actually didn't respond very well to that. And with this child, we're still considering other options because we still haven't got on top of her eczema, but she's pretty much always very red like this. This is another little child who's very itchy, very, very uncomfortable. And I just wanted you to note that her eczema just looks a little bit different to some of the eczemas that we've seen before. It takes, I think, maybe seeing a lot of eczema, but this just has a little bit of an urticarial sort of look to it. And sometimes when I see patients in clinic, you recognize that it looks a little bit different, and it suggests that maybe there could be an allergic sort of trigger to this particular widespread eruption. This is another child. This is a 7-year-old little boy who was really uncomfortable and had widespread lesions like this. And the parents' particular concern was that his nipple was completely effaced by this rash, along with all the other bits of skin that are affected. But they were particularly worried about the nipple and wondered whether there was something else going on. But I treated him, maybe you recognize this as looking very similar to the pattern of discoid eczema that I showed you before. And I treated this patient along the lines of discoid eczema. And with that, the changes over the nipple resolved as well. And nipple eczema is not uncommonly seen. So when we do have significant changes over the nipples in a child that we know have eczema, I always do initially treat it as eczema and then reconsider if it hasn't responded to eczema treatment. But so far, all of my patients have responded to eczema treatment. So yeah. You can see that he's got fairly typical discoid lesions, particularly prominent over the trunk and the limbs. He's also got a few, he's got a lesion over his chin as well. So again, discoid eczema is not an uncommon pattern of presentation. So this is an older child. So as I said, about 80% or so of patients will grow out of their eczema as they get older, but we see a significant proportion that sort of grow up with us with their eczema that never really resolves. But this patient I met in her teens. She was referred and she had quite widespread eczema, and she was actually pretty much red all over. She was almost erythrodermic, so more than 90% of her body was erythematous, and she was a little bit shivery when I saw her in clinic as well. But note the different pattern of changes. So eczema can change with age as well in terms of how it presents. And in teenagers, I tend to see quite a lot of facial involvement, neck involvement. So it's a slightly different pattern compared to the little children who will often have very flexural involvement if it is quite localized. So again, just to always think about the differential. So this is very clearly different to eczema. This is very, very localized. Behind the ears, we know very commonly affects psoriasis, and this patient has psoriasis, so it's not eczema at all. another, so the same, yeah, so very well demarcated. So another little boy, he was 2 or 3, and the referral here was that he's responding to, he's got mainly changes over his cheeks. He's responding to steroids, but it's just constant. It never resolves. It sort of gets a little bit better, but then we stop the steroids and it flares up again. So this is his right cheek, and this is his left cheek, looking a little bit more prominent, but both basically looking essentially eczematous. You can also see it's quite subtle, but he's a child of mixed race, and you can see a little bit of hypopigmentation over the cheek, which is one of the things that can cause significant concern to parents with these pigmentary changes. So what do we do with this child? Well, I always go back to the basics, and that's where we always start. And the parents had been using topical steroids, and they hadn't really been using moisturizers as a baseline. So we gave all the initial advice. So they started using moisturizers, and they used some hydrocortisone, didn't do so well, and we escalated to a little bit of Humavate, but still he kept on flaring. And then we got a little bit concerned about the fact that he was using Humavate quite regularly. So do we know where we can go with this child? So we've got in our armamentarium, we've got things like topical calcineurin inhibitors. So those are not first line for eczema management, but that is something that we can use in patients like this who are constantly needing topical steroids. And we can introduce things like Protopic, and they come in 0.1%, they come in 0.03%, and you can get Elidel cream. Now, the issue with things like Protopic is that Protopic 0.1% ointment is not licensed for use in children. Protopic 0.03% is licensed for use in children, but I tend to stick actually with Protopic 0.1% ointment because it's very effective. It has been very safe. I've never had any problems with it. And the reason it's not licensed is just the fact that the trials have not been done in children at this young age. And it's used very widely around the country, very safely with no issues, and it works very well. And so that's what I use to try and get these patients off their topical steroids. So I gradually move them from using the Humavate into using Protopic instead. So Protopic, if you're familiar with it, we need to warn them about the initial burning, stinging sensation that will occur when they start using the Protopic. I get them to use it twice a day for about 3 weeks. If the patient has already been using a topical steroid, I gradually introduce the Protopic into the regime. So I will use the Protopic at the other end of the day when they're using their topical steroid. And then gradually, on alternate day basis, I will substitute their topical steroid for Protopic, and then eventually with the aim of replacing it completely with Protopic ointment. And then once we're established on the regular Protopic ointment used twice a day, then the usual practice would be to try and reduce it to daily applications of Protopic. And the aim with Protopic, which is different to how we manage atopic eczema normally with steroids. So with steroids, usually we want to take them off it, but with Protopic, we want them to be on maintenance treatment. So 3 times a week protopic is perfectly fine as a long-term treatment to keep their skin under control. And the next time I saw this child in clinic, he was completely stable on regular protopic, skin completely clear. The hypopigmentary changes in these children take a longer time to resolve, but we can reassure these parents that this will go back to normal. And they were very happy with that. So this little boy actually had very, very bad eczema. So this photograph was taken quite a way into us having managed his eczema. So he'd been under our care for a number of years, and eventually we improved his eczema with the use of bandaging and paste bandaging as well. If you look at the BAD website from where I got the video on wet wraps, you will also see a video on using paste bandages, which is pre-medicated bandaging, which has an additional anti-inflammatory effect. And once the parent knows how to use these paste bandages, they can be very safely used at home, and they can be very useful for inflamed skin and for very dry skin. So this patient's eczema resolved very well, but the problem was that he was left with this skin that was always dry. No matter what they did, his skin was really, really dry. And if you look at this picture on the right-hand side, you can see that the texture of that skin looks abnormal. It's not even your normal dryness. There's something slightly odd about it. And if you feel it, it just feels incredibly dry. And you can see this sort of slight flakiness of the skin. Obviously, in real life, it's easier, but what this child had was an underlying ichthyosis. So they have a genetic predisposition to dryness of the skin, which is incredibly difficult for the parents to manage. And there's no treatment, there's no cure, there's nothing that we can do apart from encouraging regular moisturizers. And one of the reasons for just highlighting this at this talk is that sometimes this doesn't look as bad as some of those children that we've seen so far with atopic eczema. It just looks a bit dry. And we know that NHS guidance says that you shouldn't really prescribe moisturizers for children just with dry skin. But actually, this child has a genetic condition. He has a genetic tendency to ichthyosis. And these patients do need their moisturizers prescribed because they need lots and lots of moisturizers. And we need to supply that plentifully. And sometimes we have difficulty asking the GPs to prescribe these medications, and I would just point you to I don't know whether you can, just sorry, 1 second. I just want to, can you see this screen? So this is from Ichthyosis Support Group, and it's a website where patients with ichthyosis can get support from. And when they do have trouble having their emollients prescribed, because it is a dryness of the skin, they sometimes will go to this site in order to leverage support to get their moisturizers prescribed for their ichthyosis. The problem with their ichthyosis is that obviously it predisposes them to eczema, and they do suffer with really severe eczema if their if their underlying skin condition is not managed properly. So even though it looks quite mild, they still do need their treatments prescribing. Are you all okay? I'm quite aware that many of you were sort of available for an hour or so. We still got a few people online. Okay, so I'll carry on talking. So so this was a girl who so I would greatly appreciate your help with this child. Ongoing discomfort. She has large patches of hyperpigmentation, the flexures of both arms, hyperpigmented, thickened skin in the flexure of both arms as well as in her legs. We have attached images. She applies emollients multiple days, still experiencing generalized dryness. Her mother is concerned about the ongoing use of topical steroids and would greatly appreciate your review. So this was this child. So she had type 5 skin. So what do you think of this child? So she's her antecubital foci look thickened but quite white, and then she's got these very small papular changes over her limbs and also actually over her trunk. Can you see those tiny little papules arising from where her follicles are? And you can see it a little bit within the lichenified areas and also extending onto the other bits of her arm. You can see it here quite prominently, very follicular papules, and then you've got some lichenification over the flexural areas. And on this picture, one of the things that really concerns people with type 4 and 5 skin is hypopigmentary changes that can occur, and they are really worried about this as well as everything else. So do we know what we're dealing with here? So this patient's had lots of Humavate. She had a couple of weeks of Humavate, and she's still really struggling with her skin. She's really itchy, and it's just getting worse. These areas are expanding. These whitened areas are expanding, and they don't know why. So they came in to see us, similarly affecting her legs. She's got these follicular, tiny papular changes over her legs, and then some more thickened places over the extensor aspect of her legs. So this is a pattern of eczema again, and it's a pattern that we really need to recognize. It's very common, really very common in type 5, type 6 skin. And similar to the discoid eczema, in that follicular eczema can be really quite resistant to treatment. So it's not surprising that she hadn't responded to a short course of Humavate ointment, which is a moderate potency steroid. So actually she did pretty well with prolonged topical steroids of potent category. So when I saw them in clinic, I was not able to give them any duration for how long they need to use it for. I just said, here's your potent steroid. You just need to use it until your skin gets back to the texture that you would expect to have. And they did that religiously, and they actually did very well. If she hadn't responded just to the topical steroid application, a really good way to have helped things on would have been to suggest that they use the tubular bandages that you saw in the demonstration, which could have increased the penetration of the topical steroids and therefore effect an even quicker improvement. But she didn't need that. That's obviously a little bit more cumbersome. She responded really well because she'd been applying good quantities of the topical steroid as prescribed until she improved, and then she gradually cut things down. Okay, this is just a spot diagnosis on the same theme that we're talking about. So she's got hypopigmentary changes over her face only. Any ideas what this is? So she's a girl of Indian origin, and these changes become particularly prominent in the sun. But they've been recurring over a number of years and are sort of getting worse. Anybody got any ideas what we're dealing with here? No responses. So this is pityriasis alba. Pityriasis alba is a form of eczema that we can see in all skin types, but it's particularly obvious in these sort of skin types when you get quite dramatic hypopigmentary changes as a result of, I mean, it's a mild eczema, so you've got this hypopigmentation and it's a little bit dry as well. But what it's really important to note is that this is not vitiligo. So we often get these patients referred up with, is this vitiligo? But this hypopigmentary change is quite poorly defined. You can see that it's sort of merging into her normal skin. And because it's pityriasis alba, i.e. a form of eczema, she did very, very well with plenty of moisturizers, lots of sun creams, and I used a little bit of moderate strength steroids. These don't need potent steroids, it's just a little bit of moderate steroids, and she did really well. And the psychological impact of these changes on her face were huge. They were worried, could this be vitiligo and could it become widespread? So they didn't know what it was. And any change of skin colouring in this sort of skin colour background is particularly notable. So we need to be able to recognise this. So it's pityriasis alba. And it's actually really common. It's really common and it's under-recognised. And it's also not commonly treated in primary care, and even in secondary care, it's not always treated. But there's a lot that we can do to improve things for these patients. Okay, I've got a couple. How do you feel? Do you want me to wrap up? I've just got a couple more cases. What's your feeling? I'm very conscious that you had a limited time available. What do you guys feel? Do you want me to carry on?
It's okay. That's for me.
You're okay?
Yeah, I'm all right.
Okay.
I don't know about others though.
Okay, well, let's carry on. Let's see. Here we go. Okay. So this was a patient. So obviously we don't, to put it mildly, we don't encourage direct contact from patients. But I got this email from a parent, from somebody who was not under my care at all. It was a very random email saying, I'm emailing on behalf of my son and his date of birth. For the past year, he has been suffering from severe eczema, which has worsened over the last 3 to 4 months. From a patch on his right foot, it has now spread over both feet and up his leg behind his knees. It has become so severe that he is not able to wear shoes, and he has missed a month off school. It is causing him so much discomfort that once the itching and stinging starts, he is crying 2-3 times a day and even at night. Night times are hard as he will be awake for a good few hours because of the itching and discomfort. We have tried cetirizine. This has caused him to get spots all over, and to be honest, it didn't help at all. Also, he is shedding skin on his feet and his leg. We have tried various creams. At first, they seem to work, but then his skin becomes hypersensitive and he has a worsening reaction. I'm now using Cetraben and clobetasone. So she's gone from using something, and now they are on clobetasone. So they're now on a moderate strength steroid cream. Mentally, this is draining my son and me. I don't know how much more we can take. Please, can you help us? We are desperate. Our GP requested a dermatology appointment back in March. We have not heard anything. They have now expedited the appointment and we have yet to hear anything. I would really appreciate if you could take the time to review his case. This is a 9-year-old boy who is finding it hard to continue his daily routine. I have attached some photos to give you an idea of the pain and the discomfort he is going through. So, as I said, we don't usually get messages directly from patients, and often, we don't respond to patients' direct contact. They're not patients who are under us. But the photos that came along with this request for a 9-year-old boy looked like this. And you can just imagine how hard that would be for a 9-year-old boy to go to school like that, and to put his socks on and his shoes on, and he's not responding to treatment, and it is getting worse. So I arranged to see this patient in clinic, and his feet were like this on both sides, and he had changes that were going up onto his legs. And from the GP letter, he'd been using clobetasone, which is moderate strength steroid, and it had been doing nothing. So he's got severe thickening, lichenification. He's got hyperpigmented changes over the lateral aspects near the lateral malleoli. You can see erosions over those areas where the skin is so itchy that he's scratching and making marks in the skin. So what did we, how did the assessment go of this child? He was actually a really, really stoic child, and actually a very sensible sort of parent who had been sitting very patiently waiting to see us. When I saw this child, we had to do something, and we had to do something quickly. So usually in a child of this age, so in a 9-year-old, I would hardly use hydrocortisone at all, except for the face, because it's really mild. It's usually not going to do anything at all if you use it over the body. So I just don't use it. And usually when they come to us, they've had it prescribed in primary care, and we know it hasn't worked, so we need to move up. Is he going to do well with Humavate? Well, he's already had Humavate, and he hadn't been doing well and been using Humavate for a long time. So the next step up, so should we give him a potent steroid? So the things to consider, this has been going on for a very long time, and this child has got significant lichenification. The whole family are struggling, they don't know what to do, and they're just desperate for help. So what I did is actually I dived straight in and I went right up to the top of the ladder and prescribed him some Dermavate ointment. So we wouldn't normally prescribe Dermavate ointment for a child, but in this instance I wanted to do something to make an impact. So GPs often, not often, but GPs will sometimes prescribe prednisolone for children's eczema that's really flaring. And that is something that I have never done whilst I've been a consultant at Norfolk Norwich. I've never prescribed prednisolone because what we find is that it might improve things a little bit, but when the prednisolone is taken away, you will often see a flare in that eczema. So it really is not, it's not worth doing. So that's why I went in with Dermovate. And I, like I do with a patient who's got significant lichenification like that, I wanted him to use it until things get better. Obviously, I wouldn't prescribe Dermovate without keeping this child under close follow-up with me. So I saw him in a couple of weeks, and a couple of weeks later, that's his skin. So to think that he just needed some treatment that was appropriate to the severity of the changes that we were seeing, he just needed to have that treatment. And things had been going on for such a long time in primary care. That is the state that he got himself into. The other thing to consider with this child is that actually, if you look at the toes, and if you look at where the sort of the rest of the foot starts, it's quite well demarcated. So with things that are really well demarcated, the other thing that we need to think about is whether it could be something like a fungal infection. So he did have fungal scrapings taken. There was no evidence of fungal infection, so I was happy to go ahead with the hydrocortisone. So you can see a couple of weeks later, there's massive improvement. He's still got significant changes, but it's markedly improved. So with good improvement, once you see them on a regular basis, you can keep on making changes to the treatment. So the Dermovate can go from being used on a daily basis. There are two ways that you can cut it down. You can either ask them to use it less often, or you can move downwards to the next level down. So move him down to a potent steroid, so down to something called Elecon ointment. And this is something that we just need to educate our patients. So I normally do not give the patients just one topical steroid. What I do is I assess in my mind how well I think that the parent has understood what I'm telling them. And if I feel like they have a really good grasp of what I've tried to explain to them in terms of the topical steroid ladder, i.e. really severe eczema, you give them a potent steroid, less severe eczema, you give them a moderate strength steroid, and you assess their eczema and you look to see how bad it is. And depending on that, you can decide which steroid you're going to give them. If they can understand that, if I get a feeling that they can understand that, I will be happy to give them both with a written explanation of which one is strong and when to use it. And this parent was very able to understand. In fact, the child was very able to understand. And so they had both. And so they gradually cut their steroid use down. You can see that still here, there's significant lichenification over the toes, for example, even over the ankles. You can see that the skin markings are quite prominent. And that's a sign that there is thickening of the skin. The hypopigmentary changes, which may be sometimes bothering the patients the most, they will resolve over time. What we need to do is to resolve the eczema. We need to treat the eczema, and the hypopigmentary change resolution will come with time. So they gradually reduce their potency, and now we've got very localized eczema going on here on that foot. And you can see what a big change that was. So when you get very localized eczema, again, on the videos, on the BAD website, you can see how we can use things like hydrocolloid dressings with steroids underneath to improve the penetration of the steroids in order to improve localized lichenified areas. So they were really pleased with how they progressed. This was his eyelids at one point. He had slight thickening over the eyelids. So again, as I mentioned before, eyelid eczema, I would start with moisturizers, a bit of hydrocortisone. But if that hasn't helped, I would give a short burst of Humavate. Definitely not for long periods, but just a very short course, and that will often just bring it back down. And then you can aim to carry things on with a mild steroid, or even to introduce the topical calcineurin inhibitors. For all of these things like topical calcineurin inhibitors, or there are so many things that if you need information, there's so much information that you need to give to patients when you see them in clinic. If you go to the British Association of Dermatology website, you will see a whole host of patient information leaflets on all the sort of things that you're going to need. And obviously that's a really good way just to reinforce what you've told the patient parent in clinic. So this is the final one that I'm going to tell you about. This is a little girl. She's a 1 year old, 1 year, 4 months, and she was referred to dermatology in April of 2023. Ongoing skin problems, presents with skin clearly not under control. This is now global, with what looks to be secondary bacterial infection. She is distressed daily and is struggling with her sleep due to itching and pain. Please see attached pictures. Pictures are always good. If you've got somebody in primary care that you're really worried about, send some pictures in so that we can get an idea of how bad the situation is, because otherwise it's very difficult for us to know the urgency of how quickly we need to see these patients. And just a quick photo will just give us a really good idea. I have given flucloxacillin and I've given advice on emollient wraps and steroid use. So at this point, April 2023, our waiting list to see patients was actually very long. And unfortunately, this patient was not going to get seen very quickly at all. Unfortunately, I hadn't seen this patient's pictures myself, but this is what the pictures were looking like. And she had erosions around her mouth. And actually the GP at that time, facing a really long wait in dermatology, had been trying to do what they could. And actually this child ended up being referred on to the allergy teams, as well as waiting for the dermatology referral. So the referral was picked up by a pediatric dietitian, and they had a telephone consultation for this in July 2023. So that was a few months after being referred to dermatology. Thank you for referring Maisie for assistance with cow's milk protein and soy allergy. So they haven't mentioned that to us, but maybe in the interim, they had sort of diagnosed her with a cow's milk protein and soy allergy in the community. Maisie is 19 months old and has trouble with eczema, which was more severe once she started on formula milk. And this has improved since mum has changed her onto oat milk. She's now being seen by the dietitian and she's now on oat milk. She's basically dairy-free now, and she's also avoiding soya. So presumably those pictures, it had improved since then. Maisie's diet is good and varied and inclusive of egg, wheat, fish, peanuts, tree nuts, cashew, and sesame. So slightly better eczema, and she's on oat milk, whereas the eczema was quite severe when she was on formula milk. So telephone consultation with the dietitian. So they've discussed that Maisie is likely to develop increased tolerance to both milk and soya as the gut matures. And mum can trial gradual introduction of these foods using a ladder approach. So the eczema is a little bit better. And so the dietitian has advised that mum can gradually try now and introduce. So obviously this is the new thinking, that these allergenic foods need to be gradually introduced into their diet as early on as possible in order to develop tolerance. So that's all the thinking behind gradually introducing this milk and soya. So advised to move up ladder at Maisie's pace. They have not been made a follow-up appointment, but will remain on PIFU. So if they get into trouble for the next 2 years, they can get in touch. And that was the advice they were given. So we've got, I put a picture in of a little weighing scale here. So the problem that we have is that this child has got really bad, she did have really bad eczema, particularly periorally, which improved when the milk was changed slightly. And then she's been asked to reintroduce gradually the milk and soya over time. So the parents still haven't seen dermatology, and they're now, all they have now is the dietitian's advice. So what do they do, and what did they do? So dietitian move up ladder, and obviously dermatologists, we want to make sure that the eczema is really, really well controlled. So they actually had another appointment even before, still haven't seen dermatology. So dermatology starts taking a really long time, and they have a face-to-face consultation in October with the dietitian. She's now 22 months of age, says has milk and soya allergies. You have concerns that there may be something else driving her eczema, which flares regularly. And you've been using a steroid cream to keep this under control. So she's still needing steroid creams to keep this eczema around the mouth under control. And you have not tried the milk and soya ladder yet due to concerns about her eczema. So some parents do think about being advised to introduce milk and soya, but the thing is, not all parents do. If parents are given the go-ahead to introduce milk and to introduce soya, they've been given that advice from a healthcare professional, and they will go on that advice and they will keep on introducing the milk and soya. But what could happen over time, as the child continues to have milk and soya, is that eczema can start to revert back to being really bad, because it may be that they had a non-IgE mediated driven eczema. So it wasn't an immediate reaction to them having the milk or soya, but it was a gradual worsening and worsening of the eczema, which is what happened. So this child was eventually seen in dermatology. No, we're still being seen by dietitians, so still not being seen by dermatology. You suspect her eczema flares may be driven by other foods, although we discussed that eczema does tend to naturally flare and then improve. So that's really, really difficult, because eczema does flare by itself, and that makes it really, really difficult for parents to pinpoint what is causing the eczema to flare. Is it just the eczema? Or is it something else? And this will constantly go round and round and round in their heads, and they get to the point where they just do not know what to do. Of the other foods that you describe, egg would be the most likely culprit. So you could consider a short trial of excluding egg from the diet. Flares could be due to more environmental triggers. So like we discussed, like the little girl who was 8 who was flaring because of exposure to dogs, cats, house dust mites, etc. It's quite possible that these flares are due to environmental triggers. And then there are things like tomatoes, which would flare most people's eczema up. It would flare it on the face because of the irritant effect. So you just get to a point where they just have really bad eczema, particularly over the face, and nobody knows what to do. Again, still, it's worth keeping up on top with eczema management, judicious use of extra creams, discuss with GP. That's from the pediatric dietitian. So anyway, finally seen by dermatology, and we went back to basics with managing that eczema, and that's the crucial thing. If the eczema management is not right, and if the eczema is not back down to being properly controlled, it is really difficult unless a patient has got clear skin. It's really very difficult to know if there is anything that is flaring their eczema or not. If the skin is clear, it's obvious. Parents can keep an eye, keep a diary, and they know what happens. If you've already got flared eczema that's constantly flaring, you have no idea what's going on. The parent has got no idea. So when we saw her, the eczema was not fully controlled. It's difficult to note when reacting to foods. Parent also had steroid phobia. That's something that we haven't talked about. Steroid phobia is rife. Topical steroid withdrawal is really rife as well. But what we focused on was managing that eczema. And with eczema on the face, you can often find that introducing things like Canesten HC twice a day or Dactacort twice a day. So they've got some antifungal components as well as the topical steroids, and sometimes just introducing those extra things to managing their eczema along with plenty of moisturizers can really help with facial eczema. The other thing with facial eczema that can be really useful is I ask them to put on a layer of moisturizing before they eat. And the reason for that is that so that they have got a barrier between their skin and the food that comes into contact with it. And so those irritant things are less likely to penetrate deeper down into the skin, like in the photo that we saw of the skin barrier. They're less likely to penetrate deeper down and then aggravate the eczema. So barrier onto cheeks before eating, and then when you've finished eating, don't use wet wipes, because wet wipes can have things that can irritate the skin as well. Just use a little bit of cotton wool, wet it slightly, put a little bit of moisturizer on and gently wipe the skin down. And that will just cleanse it of any residual irritants from the meal and leave it with a good layer of moisture. And over time, if you keep on doing that, you're reducing the contact with any irritants, you're building up the skin's natural barrier, which is intrinsically defective in children who have eczema, but you're just trying to promote a good barrier in order to reduce ongoing inflammation. Okay, so I'm going to end there. So that is, I mean, those are just the principles of managing eczema absolutely anywhere. Please focus on moisturizing, getting the topical steroid strength right, and that's based on a background of what's been used already, and how bad the eczema is will help you guide at what strength you want to go in at. If it's really bad, like the boy with the really lichenified, really exudative eczema on the legs, I went straight in at Dermovate. I don't expect in primary care that anybody would often go in with Dermovate at all, but certainly escalating to a potent steroid before they've had a chance to be seen in secondary care dermatology would be very reasonable in someone whose skin is really very flared. So I'm going to end there. Thank you very much for listening.
Thank you, Natasha. This is a very
Thank you.
high caliber teaching. I really learned a lot. It was really good. I enjoyed the teaching. Thank you very much.
You're
I
welcome.
don't know, yeah, if any have got any of the other colleagues from primary care have any question or you have any comment for Natasha, Um, I think we have seen a complete catalog or album of cases today. I don't think that we can find this really easily in teaching or training. Any comments? Any questions from colleagues?
So please do, you've been given a QR code and that on the email that Wala initially sent to you, and that gives you access to a lot of the websites that we use to give the patient information leaflets on many of the issues that affect parents with children with eczema. Pretty much all the questions that we get asked in clinic, the answers to those are contained somewhere within all those leaflets. So you obviously you need to know where to go, and that takes a little bit of time. It takes a little bit of homework, a little bit of doing. But once you know where it is, you can dig those out when you see the patients in clinic.
So if there's no further comment, I think someone was planning to ask a question or make a comment. You opened your mic. Any comment you would like to add? If yeah, please go ahead.
Okay, thank you so much, Natasha. It was very informative. I learned a lot. I wanted to ask, when you're managing eczema and you have to use both the emollients and the steroids at the same time, I think you mentioned you have to give 2 hours duration between the two. I don't know if I heard you right.
No, so it's not 2 hours duration. It's half an hour between the two. So it doesn't matter which way you treat, whether it's the emollient first or the steroids first, but just half an hour, if at all possible, if they're able to incorporate that into their regime. You know, children are sometimes very, very difficult to manage. If the more often moisturizers can go on, the better. But at least get those steroids in at some point, and then even if it's later on in the day, just try and catch up on the moisturizing. But yeah, half an hour so that the steroid doesn't get diluted.
Okay. Thank you very much. Thank you.
Natasha, what about things like swimming and bath and shower?
So bath and shower. So often patients are told not to bathe and shower regularly on a daily basis. I don't restrict their showering and bathing at all. All I say is that make sure that you're not using any soaps, any bubble baths. Please try and use the pre-applied soap substitutes when you do bathe. Keep the bath or shower tepid, so not really hot. But just a little bit warm is absolutely fine, and used in that way, there's no restriction on bathing at all. In terms of swimming, obviously if the eczema is really active, it's probably going to sting them a little bit when they're swimming, but if it's under slightly better control, make sure you moisturize all over before you get in the pool, and then once you've finished, have a good shower down. And then put a layer of moisturizer on afterwards. So obviously we do not want to restrict the activities that these children are involved in. They already have significant impact on their quality of life. So we're going to do what we can to protect their skin whilst they're doing that.
Sure. And finally, if there's no other question, sunscreen during the summer for eczema.
So sunscreens, there aren't any particular sunscreens that we would recommend in particular, but whatever you are using, I would just say to try it on a little patch before to make sure that they aren't reacting to it. And if they're fine on that little patch, then go ahead and apply it all over. But yeah, irritated eczema, anything applied to it can cause further irritation. So the patch test is important.
Thank you. Thank you very much, Natasha, and thank you, colleagues. And we will continue on this pilot, so the feedback is important.
Lovely. Okay, so I think I did press record on here, so hopefully that will be accessible, I hope, to everybody else at a later date. Lovely. Thank you very much, everybody, for joining. Thank you.
Okay, bye.
Take care. Bye-bye.